Good afternoon. At the outset, I would like to thank Dr. Nimi for giving me this opportunity. So the topic I'm going to present is the Rising to the Challenge, Understanding Keratoconus. I'll go through a small introduction, epidemiology, etiology, pathophysiology, clinical features, classification, and when to screen, and a short note on keratoconus in pediatric eyes. So we all know keratoconus is derived from a Greek word which is kerato means cornea and conus means cone. And by definition, it's the most common primary ectasia of the disorder, primary ectasia of the cornea with bilateral, asymmetric, progressive steepening and thinning of cornea, which results in irregular astigmatism and visual impairment. Coming to the epidemiology, in a recent study with a meta-analysis done in, along 15 countries, they found out the global prevalence to be around 138 per 100,000 population. And a newer study from US where they used sensitive tomography, they found the prevalence rate to be around 1 in 375. In 2024, a study from the LVPI, they have found the prevalence to be around 0.62%, and they have also noticed that prevalence was much common in children less than 16 years. It's a disease of the second decade, that's adolescence and early adulthood. So this study from the LVPI, they found out in their study the males had a preponderance, and they also found out that upper middle socioeconomic class and the upper socioeconomic classes had more keratoconus. Professionals were more having risk of keratoconus, and as the decade passed on, that increased the risk for keratoconus. It's a bilateral disease and asymmetrical. Usually 40% present as unilateral. And when we look for changes in the other eye, usually they start with a subtle signs, and more common in the Middle East population. So we know that the most common major and modifiable factor is the eye rubbing. So constant mechanical trauma, either by eye rubbing or due to some use of contact lens, can cause micro trauma, which cause increases in the enzymatic degradation and thus cause ectasia. Another common etiological factor is a family history. Always we look for family history for glaucoma and retinitis pigmentosa. Also always ask for keratoconus history in family, because it's around 15 to 67% high risk for developing glaucoma with a family history. And when checked, familial KC is more autosomal dominant, and it is associated with a chromosome with 5. Overall, KC is due to environmental triggers in a genetically susceptible people. Other etiological factors like systemic association with collagen vascular diseases, which is the Ehlers-Danlos syndrome, osteogenesis imperfecta, Noonan syndrome, all these can have a chance for keratoconus. Especially in Down syndrome, children always tend to rub the eyes, so that patients are more prone for keratoconus. Coming to pathophysiology, as already discussed, keratoconus was thought initially as a non-inflammatory disease, but now recent evidences are showing it has more of inflammatory pathology. So other than that, keratoconus formation is due to mechanical weakness, and the protein signaling pathways also show that altered expression, that CD34 levels in keratocytes have been seen to be reduced, and increased in laminin and fibronectin in the scarred areas, which says that this is a dysregulated wound healing which is happening. Other than that, oxidative stress also plays a role, that increase in the reactive oxygen species, reduced in the ALDH3 enzymes, and most importantly, the enzymatic activities using increase in the proteinases and reduce tissue inhibitors of proteinases all cause stromal thinning. And the damage gradient in the corneal apex, they are more prone to stromal thinning rather than the periphery of the cornea. Clinical features in the early stages, it can present as blurred vision, monocular diplopia, halos, glare, frequent changes of glasses, not happy with the having a contact lens, and in case of an acute eye drops, it's always sudden drop of vision and a painful visual loss. So the disease progresses till 4th decade, and thereby it stabilizes. So these are the various signs which we are associated with keratoconus. This is all named signs. So this is the Charloy oil droplet sign seen in the retinoscopy, retroillumination. And also this is the scissoring reflex. That is, it moves like arms of a scissor in case of a irregular astigmatism. Then the Fleischer's ring, which is one of the classical feature of keratoconus. Then this is the Vaux striae, which is the posterior stress line which disappears on pressure. And another most common feature is the Bowman's layer scarring. Scarring in the anterior stroma due to tears in the Bowman's layer. Advanced cases, we can see the Munson strain, which is the V-shaped indentation of the lower lid in downgaze due to the prominent cone. And for this picture shows the acute hydrops where the cornea will be seen as fully edematous. So basically, the keratoconus and pellucid marginal degeneration occurs. We just differentiating between pellucid marginal and keratoconus. It's that inferior temporal thinning in case of keratoconus, and then in the pellucid marginal degeneration, there is an inferior 1 to 2 millimeters band of thinning, and the ectasia is usually above the area of thinning. These are the various classifications. And now I'll just give a short note on whom to screen. Always with a patient with a history of atopy, VKC, atopic keratoconjunctivitis, allergic conjunctivitis, take a K reading. And on routine examination, when we find the K reading of more than 48 diopter, try to do a corneal topography. And patients with high irregular astigmatism, and the patients with recent onset of refractive error in the first decade or in the second decade, or a patient with a family history. Keratoconus in pediatrics, just a short note, it's a more aggressive disease, it progresses rapidly, so the close follow-up is essential in these cases. Coming to the take-home message, keratoconus is a progressive corneal ectasia with conical protrusion. Etiology is multifactorial. Early diseases can appear clinically normal, and timely intervention can prevent progression and preserve vision. Thank you.